Cock-a-doodle-doo, everybody. Good morning. How are we? It's 6 a.m. and we're doing some pulmonary pharmacology. So without further ado, here's my tech assistant. Here she is, and we're getting in. We're not messing around. We got mnemonics. We're learning good stuff. Let's dive in. Here we go. So as we're looking at obstructive pulmonary pharmacology, we just want to make sure that we really identify what an obstruction is. So there's three main routes of obstruction when we're looking at the pulmonary system. There's secretions that actually fill that lumen that'll cause obstruction. And there's smooth muscle hypertrophy. So the smooth muscle around the actual artery is then constricting. And then we also have muscle edema. The muscle edema can also be your third form of obstruction. So when looking at all of the drugs, we're really using all of these drugs to only assess two diseases. The first one is COPD. The main symptom of COPD is just shortness of breath or a chronic cough. The symptom hallmark of that, it needs to be for at least 3 months and over 2 years. So guys, this is a chronic disorder. COPD, don't smoke, don't do it, never do it. Diagnostic hallmark for this and for both of them is there's this thing called the the FVC ratio that needs to be less than 0.7. So what this does is this measures how fast you can exert 70% of your lung volume. And this is really important because it really is a key indicator to the function of your lungs. So if that is less than 70% within the first second, you are showing signs of obstruction. The second way to get obstruction is asthma. We all know someone who has asthma. Grab the albuterol, hit the inhaler. It's everywhere. It's pervasive. The big symptom hallmark for asthma is it's episodic dyspnea. So you're having these sudden onsets of shortness of breath where you can't breathe. It's an inflammatory process. The way that we distinguish this with COPD is it is reversible. You will take a bronchodilator and we will see a marked response. For us to start doing a workup with asthma, the big thing is that you may have greater than 2 events per week. You will have daytime symptoms for greater than 2 times per week, and then you could be experiencing nighttime awakening. Any of those things, and you will go past the initial response, and we'll be doing the more controlled management. Like I said, all these drugs are to assess the 2 diseases that we just mentioned. When we're looking at COPD, the first thing that you're going to do if you have the most mild amount of symptoms is you're going to do a short or long-acting bronchodilator. It's the first thing that you're going to do. You're going to hit it with the beta agonist. The second thing is you're going to do a LAMA or a LABA. So that is just a long-acting muscarinic agonist, or you're going to do the long-acting beta agonist. The group C, you have to hit them with the muscarinic. So if you're getting to group C, and you guys can look up the criteria for each of these, you got to hit them with the muscarinic. And in group D, you have a couple options, but you're just throwing more at this. This is your severe COPD. This is your person that's experiencing severe shortness of breath without even exercise. And you could do a LAMA or a LABA, or you could do a LAMA and then a steroid. For asthma, we start off with asthma. The first line treatment, once we're looking to control that on a daily level, is we're doing Fluctiasone. The second thing that we're doing is a low dose corticosteroid paired with LABA. And then for the third step, if those two don't work, the third line is doing a high dose corticosteroid with a LABA. So I'm over here saying LABA, LAMA, banum, but what do those actually mean? So let's dive into the pharmacology, everybody. My favorite part, where I get to share mnemonics that are really working for me, hoping that they work for you. Here we go. So the first line are the beta agonists. Remember, what does beta-2 do? Yeah, that's right. Beta-2 bronchodilates. So what these drugs do is these help enhance our ability to bronchodilate and open up those airways. We've all heard it. The first one is albuterol. The thing to notice about all the beta agonists is they all end with -erol. So we got albuterol, Salmeterol, Formoterol. Great drugs. They're all beta-2 agonists. They all hyperpolarize the cell by opening up those potassium channels. And what this does is this decreases pro-inflammatory markers, and then it increases things that are anti-inflammatory, like lipocortin-1. How are we going to remember this? Well, we all have probably heard the word albuterol, but the key distinguishment between these aerols is albuterol is the fast guy. So A is the fast guy on the block. Albuterol fast, Salmeterol, Formoterol, long lasting. There we go, everybody. That's the beta agonist. We got albuterol, Salmeterol, Formoterol, albuterol, the fast guy. Now we're diving into the muscarinic antagonists. These are the guys that we are using for the group B, C, COPD. These are the muscarinics. And what we're thinking with the muscarinics, the mnemonic for Ipratropium and Tiotropium is we're just relaxing and chilling and doing some IV tropium, you know, just relaxing. We're just antagonizing the muscarinic receptors. We're not hitting the vagus nerve. The mnemonic is relaxed on tropium. We got Ipratropium and Tiotropium. The big thing with these guys is that they stop bronchospasms. The vagus nerve is typically innervated and mediated by acetylcholine. These actually stop M1 and M3 receptors from binding to acetylcholine, so we get deactivation of that vagus nerve. So we get relaxation, we get the bronchodilation, we don't get any more bronchospasms, we're relaxed on tropium, Ipratropium, Tiotropium. Don't forget it. First one, Ipratropium, I before T's, I before T's. I is the short acting, T is the long acting. So as you can see, as we differentiate between these different drugs, we're really delineating between short acting and long acting. But these classes of drugs are being used to target these two diseases. So let's get into the corticosteroids. This is going to be the first hitter that you're going to do with asthma when we're trying to get on a controlled daily regimen. The first hitter is fluticasone. The mnemonic, you get the flu through the mouth. That's contrasted with prednisone, which is a systemic steroid that can be used. And the mnemonic for prednisone is like, when I got pregnant, it affected my whole body. So prednisone goes through the whole entire body. Fluticasone flew just through the mouth. The mechanism of action for these two are their glucocorticoid receptor glucocorticoid receptor agonists. They're going to have an anti-inflammatory effect, which is the main driver of what? Yeah, that's right, asthma. Just be aware that prednisone has severe side effects. So the frontline treatment for using a corticosteroid is really the fluticasone. Rarely have I seen in the practice prednisone go around. Now, moving on to the MABs. MABs, we remember from last time, MABs is our key indicator for monoclonal antibodies. The first one is Mepolizumab. Mepolizumab, the mnemonic is a little bit of a stretch, but work with me here. If we picture Mepolizumab, we got to clean me up on aisle 5. Mepolizumab, clean me up on aisle 5. The mechanism of action is it binds free interleukin 5. Mepolizumab binds free interleukin 5. This helps control asthma. It's an immune regulated drug that we can use to combat asthma if the first 3 lines aren't working. The second one, Omalizumab. The mnemonic, OMA-G. So the second immune modulating pharmaceutical drug that we can use for asthma is Omalizumab. OMA-G binds serum IgE bodies. So we're just trying to make that connection that Omalizumab is mediating IgE. Mepolizumab is binding IL-5. Clean up on IL-5. OMA-G. We're halfway through. Thank you for sticking with me, folks. We're working with the pulmonary system. Deep breath and expiration. Here we go. So to finish this off, we got Montelukast. This one's a hard one. Montelukast. We're thinking of the Montana sisters. So the big receptor that Montelukast is targeting is it's an antagonist of the cis-LTR1 receptor. So we're thinking Montelukast, Montana sisters, cis, cis-LTR. These are hard, and we're really getting into the minutiae here with little drugs that are used, tertiary drugs that are used, 4th, 5th line for asthma and COPD. But Montelukast is one that can be used. The second one is Rofumilast. Rofumilast. The mnemonic, we're looking at the 4 first letters here, ROFL. What does that stand for? Roll on floor laughing. We're roll on floor laughing at camp because the mechanism of action, it's a PDE4 inhibitor, which increases cyclic AMP. We're all rolling on the floor laughing at camp. Rofumilast, the PDE4 inhibitor. Moving along the line, we're almost there, folks. Hang with me. We're close. The second one is Theophylline. Theophylline is also a phosphodiesterase inhibitor, a lot like Rofumilast. This also increases CAMP, and then the mnemonic for this one is really easy. It's just Theo, PD3. The means 3. Theo, 3, Theophylline, PDE3 inhibitor. Increases cyclic AMP. It can help drive asthma out of the door, and it has an anti-inflammatory effect. Moving down the line, we've got just a couple more. We got Cromolyn. Cromolyn. Cromolyn's a great one. And the mnemonic that I concocted is don't touch me mast, no chromo. Don't touch me mast, no chromo. Cromolyn, it's a mast cell stabilizer. So this means that it prohibits the release of histamine, which is like a vasoconstrictor. So that can help alleviate a lot of those major symptoms that we can see with asthma. And the last one, this is one that you see in a lot of infectious diseases, especially bacterial infections, is azithromycin. Azithromycin is typically an antibiotic, and the mechanism of action is it inhibits the 50S subunit of bacteria. But in this case, there's also an anti-inflammatory effect. This could be like a phagocyte mediated anti-inflammatory effect. And just be aware that azithromycin can have an effect on asthma with the anti-inflammatory effect. So the last things that we're going through is one big driver of asthma is just triggers. What's actually causing that inflammation? So one thing to keep in mind and to keep in your back pocket is the antihistamines, the allergy drugs. This could also be another angle that you could use for your patients that are getting these really severe asthma attacks. So with the antihistamines, we've got 5 main drugs that are all the same. They're first generation. Now, the mnemonic for those 4 drugs, I should say, is dihydrobromopromo, dihydrobromopromo, dihydrobromopromo. Let's go down the line and say them real quick. They're a little hard. Diphenhydramine, that's the di. Hydroxyzine, that's the hydro. Brompheniramine, that's the bromo. And the last one, you know what it is, promethazine. So those are all the first generation antihistamine drugs. So those actually are the ones that have a large sedation effect and they pass the blood-brain barrier. The only one that you want to keep in your wheelhouse before with that is Loratidine. Loratidine is a second generation drug. It's non-sedating. It doesn't pass the blood-brain barrier. The mnemonic for Loratidine is, it's just Laura. She's just, you know, not the first one to come, but she's the second one. So welcome, Laura. We're still great to have you. It's going to be a good time. Make yourself at home, grab some tea. Thank you guys so much. We just covered actually obstructive lung disease. The 2 hitters are COPD and asthma. They're both obstructive diseases characterized by what? Yes, that's right. A low FEV FVC ratio, lower than 0.7. We've got a strict workup that we follow for both COPD and asthma. And then we also have those like 4th, 5th, 6th line drugs that I mentioned in the video. So thank you so much. I really appreciate your time. Don't forget to breathe and so on and so forth. Cheers.